So just starting out, I know some about you from us teaching together over the years, but there's a lot I don't know. Can you just kind of talk about your educational background, what you study and teach now?
Yeah, I started at Calvin College, which is now Calvin University in Grand Rapids, Michigan. I was a biology major as an undergrad because I was really curious about how the body worked, and I actually wanted to be a medical doctor until I hit organic chemistry and realized
Same here.
I'm good. I don't like this anymore. And I kind of floundered until I took an exercise physiology class for fun. Wow. And I saw the connection finally. It's like, it's the human body and training put together. I understand what my cross-country coaches are doing.
So you were in cross-country
I ran
in high school.
cross-country and track.
Yeah. Uh-huh.
And it's like, I finally understand why they're doing what they're doing, and the body made sense. So from Calvin, I went to Indiana University where I did my master's degree. I did a study on exercise-induced asthma and caffeine, comparing the caffeine with albuterol, which is the inhaler.
Yes.
Realized I didn't want to work with special populations.
Okay.
Because it's really hard to find subjects. And I also didn't like my advisor. So I
That's
left.
a big part. Yeah.
It's a big part of it. So if there's any undergrads looking, make sure you like your advisor before you start grad school. And from there, I went to the University of Utah, where I studied fatigue and tried to understand mechanisms of fatigue, especially muscular and pain, or muscular pain, muscular fatigue. Not really the central component, not nociceptors necessarily, but what makes your body tired, what makes your muscles sore during exercise. From there, I went to Georgetown College for a year until I came out to beautiful Santa Barbara and started teaching at Westmont College, where I teach exercise physiology as my primary class. And then I'm also the chair of the kinesiology department at this point.
Yeah. How's that going?
So far, so good.
Okay.
We've got a couple of open positions if anyone's watching or listening.
Biomechanics.
Looking for a biomechanics
okay.
position.
Yep.
So
yep.
we need someone good who can teach biomechanics.
Yeah, that's so the master's degree, the caffeine and the asthma, was there anything interesting that came out of that?
So the only kind of interesting thing was caffeine works as well as albuterol. There was no synergistic effect.
Okay, so they didn't stack.
Yeah, they didn't stack, unfortunately, but both of them prevented the drop in expiratory flow that happens with asthma. So normally if someone has exercise-induced asthma, we see a decrease in expiratory flow due to a narrowing of the airways, and albuterol and caffeine worked as well as each other. But it was the equivalent of 6 milligrams per kilogram of caffeine, which is a really high dose.
Yeah,
so
you're having a panic attack, but you can also...
Yeah. So if you forget your inhaler, if you're an asthmatic, drink 2 strong cups of coffee and you should be okay.
That's interesting.
Yeah.
So cool. Yeah, I loved talking with you when I was teaching. We were teaching at the same college together, and I was doing, sort of like a applied biomechanics and pain science and therapeutic exercise, but there seemed to be so much crossover with what you had studied in fatigue and kind of with what I was studying and teaching in pain. And it was always, besides also our shared interest, both as former athletes and exercise physiology standpoint, always fun to talk to you about these topics. So let me just ask you, from your perspective, if somebody was listening to this and they were thinking about, because this podcast is really going to be focused on health, and then obviously with kind of a focus on pain and injury and rehab and things like that, if you were thinking about somebody who just wanted to kind of boost their health and you're coming at that from an exercise physiology standpoint, what are some things you would say these are important to focus on?
That's about as broad of a question as you can get.
Okay. Yeah, totally.
But
Maybe.
I think it comes down to just the basics. If we're looking for health, it's move your body every day, lift heavy things sometimes.
Nice. Yeah.
And that really comes down to the basics of movement and exercise and health. It's move your body every day, get your heart rate up, maybe sweat a little bit, and then lift heavy things so you keep the strength as well. And you get this great benefit of keeping your heart healthy by moving, keeping your mitochondria functioning so you can make ATP, and yet you keep your muscular strength and muscular endurance so you can do the things you want to, like picking up kids or picking up grandkids down the road, where you can still do that and you're not limited.
Yeah, I love that. I love those too. I mean, I feel like we echo each other so much. Like me coming from the physical therapy background, I mean, I just can't tell you how often I'm telling people like, just try to be less sedentary. Just move as much as you can. And like you say, like lift things up that are heavy and implement resistance training. We were just talking about the power type training and those changes that happen with aging and how important that is. So when you think about, okay, that was a super broad question. I know you are a big aerobic exercise type guy. When you think about, I feel like so many of the podcasts and information I hear right now are focused on VO2 max and this predictor of it being sort of maybe the number one predictor of mortality and longevity. Would you agree with that?
I don't know if it's the number one predictor, but it's definitely a predictor. So there's some research out there that shows that as your VO2 increases, or a lot of times you'll see something called a MET, metabolic equivalent unit, which is just your VO2 divided by 3.5. So it's switching it up for some reason. But as you increase your VO2 or your MET, your mortality percentage decreases. So your chances of dying that year are decreased. And that relationship exists from very low VO2s all the way up to very high. The highest I've seen in the research is 18 METs, which is almost a VO2 of 60. Oh. And as VO2 keeps going up, mortality keeps going down. So there's a very strong linkage, and whether it's because your heart's healthier, your mitochondria are healthier, or it just suggests that you have healthier
vessels
or even just healthier habits. So there might be kind of a chicken or egg component. It's like
maybe not causation, there's some correlation there.
Yeah, so there's probably some correlation where people who have higher VO2s tend to live healthier. They probably smoke less. They move their body more. They're more likely to have healthy habits associated with it as well.
And I feel like you hear a lot that VO2 max there's a huge genetic factor to that. How much can you change it with training?
From the research, as best I can remember, it's somewhere between 10 to 15%, maybe a little bit more. So when we look at, for example, an elite athlete who comes in with a VO2 of 70 already, they're not going to be able to change their VO2 anymore.
Yeah.
They're already bumping up against that ceiling, so they're looking more at velocity at VO2, which is a power component. And before we started recording, we were talking about that and thinking about what are the components that might limit marathons and things like that. And it's like we have lactate threshold, which is trainable. We have running economy, which is trainable. But we also have this velocity at VO2 max, this power component that's trainable. So we're looking at kind of all of those. Even if VO2 is not trainable, the velocity at which we obtain VO2 could be trainable, and that could get more interesting as well.
I've never had my VO2 tested, but it's something I've always wanted to look at. And you said yours has gone down since college, and that's another thing I feel like I hear is that your VO2 almost kind of like muscle mass and strength, maybe you kind of hit a peak at some point earlier in age and then you start to kind of decline. Do we see that with VO2 max?
Definitely. So just like muscle mass kind of peaks in your mid to early 30s typically, we see the same thing with VO2. So VO2 tends to peak late 20s, early 30s, and then it has a slow decline over years. Part of it comes down to this whole idea of use it or lose it. And there's been a couple of studies that have shown elite runners who keep training and working out at a high level, their VO2 doesn't drop much. It still drops a little bit into their 40s, 50s, and 60s, but those that stop training, their VO2 drops a whole lot more. So yes, VO2 is going to decrease, but if you keep exercising, if you keep training, your VO2, just like your muscle mass, will stay much higher.
I was going to say, it's a lot like muscle mass. I think you hear the same kind of pattern, which, it's a bummer in a way to think about, I'm declining as I age, but I think also reassuring to know that like, hey, if I stick with these things and keep training, I can really offset that in a big way. So
yeah, and it's never too late to start too, which I like to think. I just remember seeing this picture of this guy who took up bodybuilding in his 70s or 80s, and he went from being overweight and unfit to being completely jacked. And it's like he put on muscle mass in his 70s and 80s, because he was actually working at it. It's going to take more work to do the same thing, but you can still be your best later in life, which in my mid 40s now, I'm
in the
kind
same
of
boat.
optimistic about that. It's like, I can still be better than I used to be.
Yeah. There's one of these imaging diagrams that I think whenever I post it on social media, it gets some of the best engagement. I think because people love to see this, but it's a cross section of two individuals' thighs. So you're seeing all their muscles and their bone mass, and it's a 70-year-old triathlete versus a 70-year-old who is sedentary. And you look at the triathlete and there's this great muscle mass, their bone looks really dense. And then the sedentary individual, the muscle is really shrunk down. You can see all this adipose, this fat layer around it. And I think, both these individuals are 70 years old, and it is kind of empowering and motivating to think how much you can maintain your musculoskeletal system, your cardiovascular system, just with kind of upkeep and maintenance and taking care of it.
And I think that's exactly it. It's, what does your muscle age look like? It's not necessarily how much muscle do you have, but to me, like, I've seen that picture as well, and the 70-year-old's leg looks more like a 35-year-old's leg. And it'd be really interesting to get in and look at how many motor units he has and like the function. But I am guessing if you looked at the number of motor units, it's going to be very similar to that of a 35-year-old. So one of the things I teach my students is this idea of grouped fiber atrophy, where as we age, our nerves are always breaking and being remolded. And if we're not using them right, the nerve will break, and then another one will come in and take over and re-innervate those muscles. So now we have larger motor units fed by one nerve, and we start to group all of our fibers together, which might decrease our fast twitch fibers, increase the slow twitch fibers, and we start to see balance impairments from...
You lose some precision, I would imagine. Is that
definitely
right?
lose some precision, and our motor units get bigger, which means if we think about like balance issues, it's harder to correct a balance thing easily, and our postural sway increases. And then as our postural sway goes up, we're more likely to fall, which leads to broken bones and injuries and more atrophy. So it's this whole idea, again, of using it or losing it. If we keep using those nerves, they stay healthier. Our body feeds and nourishes the nerves that we're using all the time. They're less likely to be damaged.
Wow. Wait, what's that called?
Grouped fiber atrophy.
Wow, that is amazing. I've never heard this before.
I've heard it at a conference, and it's like, I need to add this in because it shows that if we use our muscles, we keep our nerves happy, our nerves healthy, and our muscles stay healthier long term.
Is it a new thing in the research?
I saw it about 5 or 6 years ago at a conference, and there's a review paper on it, and it was just fascinating to think about it.
Wow. I mean, it makes so much sense. Like, we're always talking about how the ability to maintain muscle mass, bone mass, all these other things, but to maintain your nervous system, it makes sense. If you're continuing to practice movement, you're challenging it, stressing it in the right dosages, it's going to help. Do you know in that if you were to, if you're training, does it help to is it preventing the nerve from sort of degenerating or breaking, or is it that when there's remodeling, it still goes back to the same number of fibers and doesn't get large? Do you know?
I don't.
Yeah.
That's like one of those things I'm not completely sure on. I don't even know if researchers know.
Okay.
I mean, we're outside of my area of expertise.
I appreciate you saying that.
It's still fascinating to think about. And one of the things I did remember from that paper, though, is that with old age, so in this case, 75 plus is considered to be old age, very old. If somebody starts exercise in their late 70s at that point and they overdo it, you can actually cause some pretty big damage to nerves.
Wow.
And you could have some loss of muscle mass and some atrophy, because when the nerves break sometimes, we don't use those muscles. And if we're not using a muscle, they're going to atrophy until the new nerve can grow in, but they're going to be still smaller. So as we're thinking about training with older individuals who haven't been doing it, we have to be careful that we don't cause nerve damage. So I just always recommend start slow for our older listeners.
It's like the whole progressive overload, but maybe take it even slower.
Yeah.
Start down lower and start slower. That's super interesting. I've always been really fascinated with kind of the neuromuscular junction. That was the thing, like when I was like you, I didn't really know in college which direction exactly I was going to go, but I had that athletic background. I remember taking anatomy and physiology and learning, because I was always super into muscles and the ability to, I was reading Men's Health and Muscle and Fitness in high school. I was like, how can I make bigger muscles, like a lot of guys that age. But I remember learning about the neuromuscular junction and just those images of the nerve coming in and innervating the muscle and just being so fascinated by that. So that's so cool. I'd never heard about this idea that you could damage the nerve and then when it remodels it innervate more fibers and how that could affect us.
And hopefully it goes back, the neuromuscular junction goes back in the same spot, because most of the receptors for that neuromuscular junction are found underneath where the nerve usually connects.
Yeah.
So sometimes it doesn't grow back in quite the right spot, and it disrupts the neuromuscular junction.
Wow. Huh. That's amazing. That's so cool. So for you, let me just ask you while we're kind of on this, kind of thinking about exercise and thinking about all these different factors and different forms of exercise. What does your exercise schedule look like? Like, what do you do? And what would you, if you were building a program for someone, say they're like kind of new to exercise, what would that look like? Like, what would you recommend?
Well, mine's going to look different than what I'm going to recommend.
Sure. Yes.
So I'm a runner. I love running. That's my
just did a marathon
primary
first?
form of exercise. And I just did a marathon.
Nice.
It went better than I expected. I made some mistakes along the way, made a couple of training mistakes, which I paid for on the day of the race. But for me, I run 6 days a week. I make sure I take one day completely off to rest. I don't lift on that day. I don't do anything. It's my day off to let my body recover, and I'm ready to go the next day. And out of those 6 days, one day I like to get to the track now. I try to do a higher speed workout. I'm trying to improve my power, improve my speed, my run economy, hopefully my VO2 a little bit as well. And then 4 of the days tend to be slower. One day I try to do strides, which are 15 seconds building up to nearly top speed, maybe 6 or 8 of those. And I just incorporate that into what's otherwise an easy run. Again, trying to boost my power. And then I try to do a longer run as well, where I stress my metabolic system. I try to improve my ability to handle glucose and free up energy from elsewhere, and also practice taking in gels and fluids. So I try to do that and mainly kind of keep that as my main thing. Ideally, which this is something I had to drop during my marathon training because it caused too much fatigue, I'd be lifting 1 to 2 days a week as well.
Yeah.
And I would try to stack that on my hard days. So after my track day, I would lift in the afternoon. I would lift ideally after my long run. That way my easy days stay easy.
Got it.
And my hard days stay hard. Because if you're stacking your lifting, which is to me the less important thing, which I know for you is the opposite.
It's like a sin.
I know it's hard, but it's like,
Yeah.
the less important thing. So I'll do it after the run, but I want to still only do it on the hard days so my body can recover on the easy days.
That's cool. Because people ask that question all the time, because it is tricky when you're a runner or someone who's like an in-season athlete and you're wondering, it's like, okay, we have all this research on resistance training and keeping those tissues strong, but where do you put it in the program? It's tricky sometimes because the volume of stress is pretty high. So that's really cool. Now, are you basing that just on personal preference, or is it something you've seen in research? Or
I haven't seen it in the research. I've seen it from a couple of running coaches out there where they recommend just really keeping that hard day hard. Because your body does need to recover. And if you don't allow it to recover, you're more likely to get injured and then have to come and see you and get some treatment.
Yeah.
But it's, how can you find a way to help your body recover? And you don't want to be sore all the time, because then you can't play with your kids. You can't do other things outside of your day. So this is where, if I was going to someone who's newer to exercise, and again, depending on what their goal is, I would maybe, if they're looking for general health with maybe a little bit of running goals, I maybe would have them run 3 or 4 days a week, starting at 20 to 30 minutes, trying to build up to about an hour. And then on 2 days a week, I would have them lift and not run. And as they progress, then we come back and start to modify what we do. But in general, my main idea is have them do close to 150 minutes of exercise, like ACSM, the American College of Sports Medicine, recommends.
Yep.
Lift twice a week and maybe do a little flexibility as well.
Yeah, sure.
If they care.
Do you start getting tight when you're with running all the time?
Sometimes in the first few minutes, but my range of motion seems to be pretty good.
Yeah.
I may need to do a little hip and hamstring flexibility to kind of work that range of motion so my stride can, again, be a little more free.
Yeah.
But it's hard to find the time to do everything.
Yeah. So it's kind of like a 5 to 6 day kind of schedule. It's like if you were doing 3 to 4 days a week, thinking about, like you said, that 150 minutes of, what is it, moderate to vigorous cardiovascular exercise.
Yeah, where their heart rate's up, they're slightly out of breath, but can talk most of the time.
That's what you're kind of basing on. I hear that one. Okay.
Yeah, so I think one of the biggest mistakes I see people do, and I get this from my Fit for Life class, where I'm bringing in the general population at Westmont, and I'm recommending general ways to exercise. And in new people who are doing cardio, they typically go too hard every single day. So when I'm thinking moderate intensity, it's I'm breathing hard, but I could still have a full conversation with the person next to me.
Is this the zone 2 that everyone's talking about?
It's the zone.
It is.
Zone 2. So it depends if you're looking at a 3 or 5 zone model, but in a 5 zone model, zone 2 is you can have a conversation and talk to the person next to you.
Got it.
But you're still breathing a little bit harder than normal.
Is it kind of like, I sometimes hear kind of in this 120 to 140 beats per minute if you were able to track your heart rate? Is it like around there kind of?
For most people, yes.
Yeah.
Especially if they're just starting exercise, 120 to 140. As you become a little bit more advanced, again, depending on your age, it might be bumping up to about 150.
Okay.
But you can still have a full conversation.
Got it. Yeah, that's like I remember, I think you use this scale, that rating of perceived exertion. It seems like sometimes that subjective almost rating of like, it is so useful in a lot of different cases. Like, I could be tracking my heart and all these things, but can I just have a conversation while I'm exercising and using that as and it's so easy, but it seems like it works well.
I think it's almost easier than having a scale because I don't often carry an RPE scale with me.
Yeah.
So it's really hard to kind of look at it.
Totally. It was the same with pain. When I ask people 0 to 10, they're like, I don't know.
Yeah.
It's like, is it mild, moderate, severe? That's easier for people than...
Yeah, and it's like, how do you relate it to life? And it's like, oh, I can still have a conversation. It's like, oh, now I'm talking one sentence at a time. It's like, I probably need to back down.
Got it.
So if you can only talk in one sentence at a time, now you're starting to bump up into zone 3. If you're talking in 2 words at a time, you're bumping up into zone 4 or 5. And you're probably working too hard depending on what your goals are.
Yeah, I'll notice this. It's hard when you're running by yourself. I have a tendency to want to run. I think I just naturally want to go above zone 2. Like when I look at my watch, I will have a tendency, if I'm not paying attention, to get up closer to 160 beats per minute. But as soon as I slow my pace and I get back into the 140-ish, it's like even if I go above 150, I will notice that I'm extremely fatigued after those runs. They seem to just fatigue my whole system. But if I stay below 150, it seems like, of course, I can breathe easier. I could probably have a conversation. And it doesn't feel like the rest of my day, it doesn't feel like my energy's been zapped. And do you think maybe that I'm kind of crossing in between like an aerobic, anaerobic threshold or something? Or
most likely you're starting to accumulate some lactate, causing some muscle fatigue, some muscle pain. And I think also there might be something with sympathetic activation. So as intensity goes up, we activate our sympathetic system more. We release more norepinephrine and epinephrine. We get more systemic effects, and that could also lead to some fatigue to a degree.
Yeah.
And keeping the intensity low, we're not going to release quite as much epinephrine and norepinephrine. We're not going to accumulate lactate because we're clearing it as fast as we make it. And you're not putting that mechanical stress on your body the same way either.
Yeah.
Because I think one thing too, like when people run, is people forget that it's an eccentric exercise. Every time you land on the ground, your muscles are lengthening. You're slowing down your body as you come to the ground and fight gravity, and your muscles are being slightly pulled. And the slower you're going, the lower your impact forces are as well, which is going to decrease the eccentric load and decrease soreness long-term as well. I
can definitely vouch for that. I know on those days when I run fast, that's actually one of the other kind of motivating factors for me to run slower is that, well, one, like I said, I'll be fatigued. I'll just feel kind of drained later in the day. And the other is that I just end up getting really sore. I'll just be sore, especially my left hip and the muscles surrounding that region. I think that's a great point. Like those higher impact forces, we don't think about, you're having to shock absorb on each step and you have those eccentric contractions. And so, but it is tricky sometimes, especially when you're by yourself to just, I don't know, I just want to run faster. It's like, I think because my cardiovascular capacity probably can handle it to some degree, maybe. My musculoskeletal system seems to be the limiting factor, and then I pay for it the next day. So,
yeah, it's always hard to slow yourself down because like you have this, I mean, I almost think of like horses with this. So horses have three paces. They have a walk, a trot, and a gallop, and they run at a very specific speed at each of those. Humans aren't quite the same way, but I think there is still this speed where we like to be, which is not quite maximum speed, but faster than slow. And it's really hard to kind of get yourself out of it. It's almost, you have to reset your body, and it's like, it's okay to go slow. And as a runner, it's really hard to not look at your watch and go, oh, I'm running 7-minute pace or 8-minute pace or 10-minute pace, whatever slow is for you. You look at it, and it's like, this is too slow. It's like, no, it's okay. There's still benefits. You're still adding capillaries. You're still adding mitochondria during those slow runs, and you're not going to pay the price later that day, the next day. And you can still enjoy life.
Yeah. It's such an ego thing because you never want to get past either when you're out running. That's like the worst thing. But it is, I have to just let it go. And what do you know? You have that one day off. Is that structured somewhere? Is that put in a specific spot in terms of like your easier days, your harder days? Where do you put that?
I put it on Mondays because that's the day I teach all day. And I have no time to
other factors you have to
run.
consider.
So yeah. And I try to do my long runs on either Saturday or Sunday. Okay. So it's within a day of the long run.
Oh, got it.
So if I do the long run on Saturday, I'll go for a really short, easy run on Sunday just to kind of
get things moving.
Let my body move, try to get my muscles to feel a little less sore. And then I'll take Monday off irregardless. And then I do my hard day on Tuesday.
Got it.
So I'm coming into it fresh. I mean, if I could come in with a day of easy running beforehand with a couple strides before the workout, it might help. But for me, this works. I have a light day of teaching on Tuesday, so I do my workout on Tuesday. And it's about as far away as I can get from the long run, so I don't interfere with the long run.
Do you think that your history of being a cross-country runner, what age did you start that?
12, 13.
Yeah.
So freshman year of high school.
I mean, obviously you must have really built a good solid foundation, capacity, the conditioning for running. Do you think that, like, say somebody was new to running, do you think they could get to where you are now? Or do you think you have a big leg up just from starting that so early?
I think there is some benefit to starting early. I've had more time to build mitochondria, but I did take 8 years off after college for running. Just had a chronic injury. I couldn't shake until I moved to Santa Barbara and started getting on the trails instead. And
mixing up the stress,
mixing up the angle. It, I think for some reason, reset my body.
Wow.
And when I run on trails, I don't have paces to compare to.
Oh.
I don't have ego on the trails like I might have on the road. And I know I lost some mitochondria. I lost some VO2 from taking that big break, which may have actually been a good thing because now I'm coming back to it fresh and excited again. And I did other sports in between. I picked up road biking for a while and did a few other things. But I think anybody can improve and unlock what their natural limits are if they're willing to put the work in. But again, you have to start slow and build over time. I wouldn't expect somebody to go out and run a marathon in necessarily their first year of running. A lot of people do, but I think it's better to take a couple of years and gradually build so your body can handle the stress. It takes time for your muscles, for your ligaments, for your tendons, your bones to strengthen and make it so you can have whatever you want to do as a lifelong sport. For me, it's running. And it's going to take a couple of years to get your body in a position where you can do it without causing undue stress, injury, which can affect your enjoyment long term.
I love that recommendation because I think it is fascinating how much our body can adapt and how much the musculoskeletal system can adapt and how resilient it is. But people just rush into things in so many cases. So I love you saying, just think about kind of giving that expectation of how much time to think about letting that system adapt. And that's a lot of what I was thinking about with you kind of starting at that young age, because right, we see this with all these other sports, like you look at baseball pitchers and how the humerus will develop this torsion, just how the musculoskeletal system can adapt when you start something at a young age. So I always wonder that with runners, like, is there something when they started at a young age, maybe they were a cross country or a runner or a track and field athlete, did something change in their musculoskeletal system that allows them to maybe have less injuries as they get older? I don't know. Do you think I've never seen anything like this, but maybe I would imagine bone density probably goes up. Maybe. Depending on nutrition and all that, a lot of factors.
I went to American College of Sports Medicine conference this past May, and one of the keynote speakers was a bone health, bone density person.
Yeah.
And one interesting stat he gave is that your body doesn't put down any more bone after your first 100 steps of a run.
Wow.
That's all the stimulus your body will respond to for running. So anything past that, you're not adding bone density. So this is where, again, if you're a runner, you need to get in the weight room.
Yeah.
Because you need the bigger loads of moving weight. So you need to put some weight on a squat or on a deadlift to really load your system to add bone density. Running on its own won't do it.
I can see that because I remember for so long it was like weight-bearing exercise was the recommendation. And then it was like, oh, well, walking's not enough stimulus. And then I remember seeing studies where they'd compare jump training in older individuals to resistance training. And I remember, I think this was back when I was with you at Westwood, I remember seeing a study talking about that with heavy contractions, squats and deadlifts, and that you would release these myokines into your bloodstream, that one of the downstream effects was increasing bone density. So it's like not only did the tendon pull on the bone, and you had that actual mechanical force there, but you also had these myokines that would come in. Is that something, have you seen more research? Do you ever look at that, the physiology of that stuff?
I don't look at that physiology. I've looked at a couple of papers on myokines, and there's a lot of things with bone density, with like an IL-6 or not IL-6, it's the insulin growth factor, which is going to trigger the whole mTOR pathway, which builds muscle and also builds bone. And we do see cell growth from that. So the whole concept of exercise and heavy exercise and load is going to allow your muscles and bones to grow. And again, I don't know if it's going to be a jump training that's going to do it most, a weightlifting, but I just remember hearing that stats like 100 steps, that's it.
Wow.
And I won't get any more bone density after that.
Yeah. Dang, that's crazy.
Yeah. So all these people are going, yeah, running's great for bone density. It's like, a little.
So it's like, is it because you have the same impact force each time? You'd think more volume would stress the bone and it would change.
But at the same time, I think there's this catabolic effect, this bone breakdown effect of long duration.
Got it.
Which goes into the whole stress fracture component, and then couple that with runners trying to watch their weight sometimes.
Yes.
And we have this relative energy deficiency component, and we also have stress fractures.
Yeah, it gets complicated. There's a lot of factors.
Really complicated.
Well, it's like you say, if more volume of running only made your bones stronger, we wouldn't hear about stress fractures. So it makes sense.
Yeah.
You said you had an injury that sidelined you. Can you go into that a little bit?
Yeah, it was a sharp pain in the middle of my calf. It felt like somebody was jabbing a needle in and twisting, and it would happen about 1 to 2 miles into a run. So every time I would just run on flat ground, because I think it was the same motion, I would get this pain a couple of miles in, and then once it started, it wouldn't go away for weeks, and I'd try again, and it'd happen a little bit sooner, and then I'd try again, and happen a little bit sooner. The best description I saw, and I've seen this description online in a couple of places, was a calf heart attack.
Yeah.
There's just something weird going on where there's just a shooting pain in the middle of my calf, and I never identified what it was.
Yeah, I remember you talking to, because I think you would get this sometimes. Do you get it sometimes still with running, or it's been gone?
It's been gone ever since. I've been able to go back to the roads after running on the trails for a while.
Wow. So it has kind of reset.
It's reset, and I don't know what caused it in the first place. I don't know why it's gone. I don't ever want it back.
Yeah. I feel like there's some interesting stuff going on in the research. I sometimes will hear about this with what's going on with trigger points, because it doesn't seem like with imaging you can see anything there, but people have these pains in the muscle belly. It's not like it's at the tendons.
It was like
in the muscle belly.
In the muscle belly.
Yeah, so it makes you wonder. I think there's so much that's not known there with looking at kind of the neuromuscular junction and, just what could be happening. Because if you think about your calf, it's like, yeah, your tibial nerves running right through there, your tibial nerves innervating those calf muscles. What's happening? Is there something in there we don't understand that it's triggering.
Maybe there's one spot not getting oxygen, but at the same time, the gastroc can make energy anaerobically, so that shouldn't be an issue. So I just never kind of figured out what it was. Like I was almost thinking it was the sheathing around the calf was too tight.
Oh yeah.
And maybe I would have to go in and have that cut.
Like the compartment syndrome.
Compartment syndrome. And it's like, but it never felt that way. And I
Not
never
like a pressure, like a tightness. It was just
it was just a sharp pain, a sharp point, or a sharp pain in one spot. So I didn't think it was a compartment syndrome, although I was getting close to having somebody actually stick a needle in and look at the pressure in there to see if it was high. But I don't think it was ever that. And it was only running. It never happened while
using
cycling
your calf with other
or anything
things.
else. Yeah. Like I could ride a bike fine. And part of the cycling pathway, you kind of flex your foot at the end, you get that extra little bit of power. Never had any pain.
Well, I think the cool thing about your story is that it matches up, I think, with so many of the recommendations of varying the stress on your system. And I think you hear this with trail running. What was that book that was all about, studied that mountain community? Born to Run. Yes, right? And it's like, I think that's some of the hypothesis in the reduced injury risk, even though they're, this is where a lot of the minimalistic shoe, barefoot running kind of stuff came from. But one of the arguments was, well, they're trail running mostly, and that changes the stress on your system all the time. And so I think what you're saying there maybe is an interesting piece of information for people to think about. If they're doing something that's the same stress on their system all the time, maybe it's just about varying the stress and changing it. We think about cross training all the time, but maybe you're a runner and you just implement some trail running. Or what about, I'm sure back when you were doing level ground kind of running, you probably changed your shoes a lot and tried messing with that without much success.
I tried everything.
So it's literally just when you trail run.
And when I started trail running, I actually started trail hiking a lot first, because I was just going out with my dog, and it's like, okay, I'm going too slow. I need to go a little faster. So I'd started doing trail running, and at least around here, our trails are really steep. And it's pretty steep uphills, 10 to 15% grades, some over 20% grades. And it stresses the calves in some ways. And then you come down and it takes the load off and it puts it on the quads. So it's just it was the mix of stress, I think, that allowed my body to heal. And with trails, you're not doing the same foot strike over and over. And even now, even though I'm coming back to the roads a little bit more, I'm still spending 2 or 3 days a week on the trails.
Okay.
I can't do a complete road running. I get bored, for one. And two, I want to make sure I keep the variety of foot strikes so my body stays healthy.
It's not like that symptom's coming back. You're just kind of preemptively taking care of yourself. It's interesting. Even if it was like compartment syndrome, you'd think it'd come back because you're still using your calf a ton. So it's such an interesting, maybe it was just the chronic, repetitive, same type of stress over and over again. And like you said, maybe it was a vascular thing. Maybe it's something at the nerve level. Maybe it's both. There's so many pains that are interesting. And it's like, you don't really know why they're happening. People always, we all want to know why we're having a particular type of pain, but sometimes it's like, I don't really, the honest truth is I don't know. And we're just but we can still move forward and look at different ways to try and treat it and manage it. And so much of it, I think, with athletes is, let's look at your training intensity and volume, and is there particular stresses that are happening all the time, and maybe we can try and change those. So those kind of stories are interesting to hear. Like, what did you do? You had this type of pain, and what ended up changing it?
And I always kind of think back to what you said when you were teaching. It's like, you don't want to completely stop exercising, though. Maybe rest it for a couple of weeks, and then you start finding other ways to stress it. You keep moving because you don't want to lose all those other benefits of exercise. So you get on a bike, you get in the pool, you hike, and you try to prevent the pain from coming, and then you gradually reintroduce the stimulus that maybe caused it as you strengthen. So you do the strengthening stuff so it hopefully won't come back, and you can go back to doing the exercise you want. It's so unfortunate when you hear some medical provider or rehab provider tell someone to just totally rest. Oh man, it's the worst, because I think so much of the research now is that, like, let's keep you on a continued running program or a continued training program. We don't want all those negative side, all the deconditioning to kick in just while we're trying to heal this thing. And did you, thinking back when you had that start, were you doing resistance training back then? No.
Yeah, it's like there's so many factors that go into these, but it does make you wonder if like high load calf training would have changed anything.
Yeah, I started doing some lifting when I was in Utah. Learned
Mm,
some of the power movements, so I learned how to deadlift and
yeah,
clean and the jerk a little bit, and maybe that started to help, but I never did it consistently enough.
it's hard to know. Yeah.
And I just spent more time up on the trails here, which is a form of weight training to a degree. It's a form of resistance training because they're steep. And you're going to strengthen that whole posterior chain quite a bit more than you would if it's just level ground.
Yeah. No, the trails here are hard. I mean, I think I might have told you during COVID when I couldn't go to the gym, I started trail running a bunch. And I ended up, for the first time in my life, developing an Achilles tendinopathy because I was doing this totally new thing. The trails are really steep. I was trying to do them 4 days a week. And I also, I think, wasn't protecting my tendons in that normally when I go to the gym, well, I would do jumping for one. I'd be doing more kind of plyometric stuff for my Achilles tendon. And I was doing really high loading of that tendon with the different calf machines. And so it was kind of like this perfect storm of factors that came together. And I often don't take my own advice. And so I did that for a long time, just flaring it up. But I eventually transitioned to level running. I, at the time, had some, I had some really flat shoes. What's the term?
Ultra?
Yeah, the
Ultra zero drop.
Zero
shoes?
drop, zero
Yeah.
drop. So I think, that I was going into more dorsiflexion. I was stressing my Achilles tendon there. So I ended up getting more of a heel and went to flat running. And now it's gone. But it did take a long time. It took me a long time. But, that was down at my tendon. I've never had a kind of middle of the calf belly type pain like you're talking about. So,
And I've also dealt with the Achilles tendonitis.
Okay, yeah.
That was a chronic thing for me as a midfoot lander, and dealing with that is just never fun. And
yeah.
I know what I'm supposed to do. I know I'm supposed to be doing those eccentric heel drops. You've told me what I have to do, and yet I don't.
They're kind of boring.
I know, you get bored with it. It's
Yeah.
like, I can do 10 or 15 of those without an issue.
Totally. Calf raises it's like so many rehab exercises. They are not, it's like you have to find some way to kind of gamify them or make them fun because they're just, for most people, they're not. I mean, most people don't even like resistance training, and then to like these really boring kind of calf raises. It's, I mean, I have a hard time. So many of these kind of rehab exercises, I think people probably think I'm just doing them as my workout all the time, but most of the time I'm going and bench pressing and doing pull-ups, and it's when something hurts and I add them back in. I'm not even, it's not like I'm doing them all the time. Now I know, so just to change topics a little bit, I know you studied fatigue in your PhD.
Mm-hmm.
What would you say, there's so many areas you could go with fatigue, but if somebody, I think when you were studying, you used to tell me there was peripheral fatigue and central fatigue. Mm-hmm. And do you mostly study peripheral fatigue?
So the fatigue I was studying was looking at during exercise, the muscle has metabolites, and then it sends an afferent signal back to the brain. So it's kind of a combination of central and peripheral.
Got it.
So it's how does the muscle talk to the brain?
Uh-huh. Fatigue, can I ask you, is it considered an experience like pain where it's outputted by the brain?
Yes.
Uh-huh.
But so the muscle will actually mediate that. So one of the studies we did, we injected metabolites, so lactate, hydrogen ions, and ATP. And ATP is only supposed to be in your muscle, but this is exogenous ATP. It's outside of the muscle.
Got it.
Which during exercise, some ATP will leak into the interstitial fluid and it'll activate receptors. So we injected those into the thumb, and we experienced a fatiguing sensation in the thumb just by injecting the metabolites. Then if we increased the concentration, we started to experience a soreness or a throbbing sensation. And this suggested that there were two different nerves, the nerves that responded to low-dose metabolites, fatigue nerves, and they tell your brain that your muscle's getting tired. And then there's the high-dose nerves, and they would tell your brain that your muscle's now experiencing soreness or pain. So I like to tell my students when I explain this, like, hold your thumb, try to reach your pinky with your thumb and actually contract it. Mm-hmm. And as you're holding that, you're going to feel like a little fatiguing sensation in your thumb. And if you keep holding it, eventually it's going to start throbbing and feel sore. And that's the exact same thing we did. It's easy to do with a small muscle because you don't use it ever, and the metabolites will work pretty well. But all of your muscles have that same thing, and that's part of that signal of your brain. You're going to your brain, telling you that you're tired, and then there's the whole efferent, the exiting signal from your brain to your muscles. And maybe that signal gets decreased over time.
So this could be the whole, when you think about, so that signal could, so then you could become more fatigue resistant if that signal decreases. Is that what you're saying?
Yeah. So your brain won't send out, your brain might not get tired as quickly. But then you also have to look at blood flow to your brain and it's such a complicated and big topic.
It's not simple? You're telling me physiology is not simple?
I wish it was simple sometimes. I wish I could give the answer to my students. Like, it's just do this and you're cured, or you'll never feel pain or tired again. And it's so complicated. So there's been some research out of Switzerland or Austria, one of those two, where they look at fatigue in ultra runners. And they'll compare someone who's done a 50-mile race versus somebody that's compared a 200-mile race. And the muscles in the 200-mile race are less fatigued.
Whoa.
But the brain's more tired. Because the intensity is just so much lower for the muscle that it doesn't fatigue as quickly. But the brain has been working for so long that the brain is tired. So the signal from the brain is actually reduced, but the muscle itself can still work fine.
Wow. Because they're running at a slower pace, obviously, but you're still having to create that motor output for that contraction, that motor program for so much longer.
Exactly. And then decision making and trying to stay awake and making sure you're not tripping on things. So your brain is working really hard, especially if you're trying to exercise through the night multiple times. And your brain's just working really hard, but your muscles have reserve.
Wow. Yeah. So it's so cool. I mean, that's another example of where it's just not necessarily intuitive, but when you explain it, it's like, oh yeah, that makes sense. Like, I think you just don't, I think as the average person, when you think about getting fatigued, people think, oh, my muscle's burning and my muscles are getting tired. But the idea that your nervous system, you could have neural fatigue, is just this whole other area that I think most people probably have no idea about.
And there's a really good paper, I can't remember the author off the top of my head right now, and this person identified 8 potential sites of fatigue. So all the way from the brain through the spinal cord to the motor nerve to the neuromuscular junction, and then there's like 4 sites within the muscle itself where we can get fatigue. So it gets super complicated, and when you start breaking it down like that, it's like, how do you isolate each individual segment and go, okay, where is the actual fatigue? And somehow our body still perceives it as, I'm tired. My body hurts. It's time to be done. And trying to figure out how can you ignore it or push through is where it gets really interesting.
Yeah. If somebody were struggling, like say somebody was wanting to have less fatigue, I'm exercising and I want to be able to go longer, go farther, are there certain types of symptoms that would help you figure out where the fatigue is or what they would do to, or is it just a lot of it's like, okay, we don't necessarily know where it is, but these are some strategies you're going to implement to try to have better fatigue resistance?
I mean, it comes down to training.
Yeah.
I mean, that's the only answer. It's like, you have to overload the system to reduce the fatigue. There's no shortcut.
Yeah.
Okay, you can take some acetaminophen. That can help a little bit, but then we're getting into doping and there's problems there. There's actually a really cool study. Well, I'll highlight this one from Marcus Amon at Utah. This was actually when he was at Wisconsin before coming to Utah. He gave cyclists a fentanyl injection, so an epidural. He injected fentanyl into their spinal cord to block the afferent signal from the muscle to the brain. So trying to take away that muscle input. And theoretically, if you weren't able to feel muscular pain or fatigue, you would expect somebody to
push way
harder. And during this 5K time trial, you'd expect them to go 10, 20 seconds faster. This is a 5K time trial on a bike, so 6 to 7 minutes of exercise. And what he found is there was no difference. And the cyclists in the first 2.5 kilometers were putting out about 10% more power. But in the second half, they're putting out 10% less power. Even though their RPE, their perceived exertion, was almost a full point higher. Their brain was working way harder. And when we're looking at perceived effort, it's mostly from efferent signal. The efferent signal leaks out to the brain and the brain perceives it. And it's like, oh, you're working really hard. And even though they're working harder, their their time was the exact same. Power was higher at the beginning, but then there's fatigue in the muscle. They overwhelm the muscle. the brain was still sending out huge amounts of signal, but the muscle was actually just completely wiped out.
They just couldn't sense it.
They couldn't
You don't
sense
have that incoming
and
signal.
part of it, there's reduced blood flow to the muscle, their breathing was less, their heart rate was slightly less. We need the muscle to fine tune a lot of what's going on in our central kind of components, so dealing with heart rate and breathing. And without that component, we didn't send as much blood to the muscle as well.
Got it.
So there's a couple of issues there, but I think the big thing is like we need that signal, we need that fatigue and that pain signal to let us know what's happening. And one of the kind of cool things I did at Utah is I was looking at mRNA for protein. So looking at the actual receptor that receives the fatigue and pain signal and sends that signal to the brain. And exercise training caused a down regulation in the mRNA, which theoretically means less protein.
Yeah.
We weren't doing muscle biopsies, so we weren't looking at the protein. We're just looking at mRNA in the blood. But training, especially higher intensity training, seems to down regulate those receptors, which means for the next day, the next 2 days, there's a decrease in the signal being sent to the brain. And we didn't look at this part, but my guess is if we train and we repeatedly send a signal to downregulate those receptors, there's going to be fewer as we train, which means we're going to sense less fatigue.
Gotcha.
So we do need to have those hard efforts every now and then to reduce those fatigue receptors, and our brain will actually start to receive less fatigue, and you start to be trained. You can handle doing more and more as you go.
What are those hard? What do you mean when you say hard sessions? What were those? Are they like sprint kind of workouts and stuff? Or
so one of them, we looked at the receptors following a VO2 max test, so 10 to 12 minute test where by the end of it you're at maximum effort, but you're only doing probably 3 to 4 minutes of really hard cycling. We also did it following a 40K time trial, which is 70 to 80 minutes for most people at basically lactate threshold. So squarely in that zone 3 with a little bit of zone 4 at the end.
Gotcha.
And what we saw is the 40K time trial had a greater reduction in the receptors, even though the max power was less. The VO2 max test, you reached a much, much higher power overall. But the 40K time trial, because it was so long and you had so much lactate and pH and ATP being around the muscle, it caused a greater downregulation of those receptors. And I think it caused a larger training adaptation. So you need to incorporate a hard workout or two every week. And as you do that, you're going to downregulate those receptors and sense less fatigue and pain.
Yeah, it's so cool. The whole like the loop of all these things is really interesting, you know, both from fatigue and pain and looking at these kind of afferent incoming signals and then how that changes the efferent signal. And you said that when we sense fatigue, it's mostly the efferent signal, how hard we're working, that outgoing kind of motor output. That's more of what we use to kind of determine how, or that fatigue feeling.
The efferent signal is what allows us to kind of determine our rating of perceived exertion, how hard we feel like we're going.
Got it. But the actual feeling of fatigue is more the afferent, that incoming sensory kind of.
I think so, yeah. So it's kind of a different component. So I always try to ask the question of, what's your fatigue? What's your pain? What's your RPE?
Yeah.
And they mirror each other pretty well overall. I think a lot of people have a hard time distinguishing between those sensations.
Oh.
Even if I define it, it's like, okay, fatigue is when your leg feels heavy, when it feels tired. And then pain is like a throbbing sensation where it's sore. And if you try to distinguish them, you can sometimes feel it. But it's really hard for most people to kind of split those sensations up. We kind of always think of them as working together.
Yeah. It's kind of like we run into this in physical therapy with delayed onset muscle soreness versus, is this like your actual pain? You know, is this truly a pain, or is it, because some people, I mean, it is tricky if you are not someone who's used to exercising in a more intense way, and that, you know, because, and also we, you know how much your perception and what something means to you, how much that can affect pain. But, you know, to me, soreness post exercise is positive. I view it as positive, like on remodeling and building my tissue. And to some people, they look at that as like, oh, this negative thing, like I potentially got hurt here and what's happening. And it can be a tricky thing helping people kind of figure out, is this just that post-exercise soreness, or did I go too hard and maybe I flared up the symptoms that I'm coming here for? It's a tricky.
Yeah, I think that's where you almost have to reset expectations. So going into like the mental side of the game.
Yes, that's another side of your area. Yeah.
Which is kind of the area I moved into based on my resources. But it's this whole idea of the mind playing such a big role in performance and us not knowing how. So I know mental training works, but why? And thinking about even on the rehab science side of things that you're looking at, I don't know if anybody's actually looked at, does mental training help with recovery?
Yeah.
Does it help people improve their range of motion faster? Does it help someone recover from an ACL surgery sooner?
What is the mental training? What do you mean when you say mental training? What does that look like?
So I work with a sports psychologist from Dartmouth, Stephen Gonzalez. He's the head of their peak performance program there. And we've made just simple videos. And it's this idea of teaching people how to breathe when they're doing hard things, teaching people to slow down their breathing, take bigger, slower breaths, which activates the parasympathetic side rather than the sympathetic side. Because if you're in a stressful situation, most people start to hyperventilate a little bit, which further exacerbates and increases the sympathetic system, making you more tense. So even in like a rehab side, if we can slow down a patient's breathing when maybe you're working the range of motion, then they're doing something that's really uncomfortable, maybe they can have bigger adaptations and quicker gains if they can learn how to slow down. Or we teach somebody how to control the controllables. It's a buzzword I've heard from a lot of places more recently, but there's so much truth there. It's like, I can choose to focus on the things I can control and let go of those things I can't control, and I can try to modify my surroundings. So if I'm looking at rehab, maybe it's like, well, I can't control the fact that I've already torn my ACL, but I can control how hard I work at home. I can control my reactions to the discomfort as I start to break down the scar tissue and allow my ligaments and tendons to elongate again. And maybe that will help with adaptations. We can choose our attitude every day, which is a big thing. It's like, am I going to choose a reactive attitude, or am I going to pick an attitude that leaves possibility? And all of those start to lead towards gains in performance. And again, imagery. I can start to imagine myself moving my leg how I want to. I can imagine myself feeling discomfort and overcoming discomfort, whether it's in performance or rehab. And you start to see these things that cause improvements in performance. So I've finished one study on this. I'm in the middle of a second one. And I saw a 10% improvement in time trial to exhaustion. So that's somebody getting on a bike, riding at a high zone 3, low zone 4 until they can't go anymore.
Is that mostly with mental imagery, or what?
That's like with the combination of all four of those. So we just gave them videos to watch. They watched one a day for every day for 3 weeks. And by the end, 10% improvement. And even more interesting, my control group for some reason had a 10% decrease. They didn't want to be there. They were so negative about getting on the bike and doing that time trial to exhaustion because it hurts.
Hard.
It's uncomfortable. Like you have to go to pretty dark places to keep pushing through when you have that much lactate kind of building up in your legs.
Wait, so what were those for again? Can you say them?
It was breathing.
Breathing.
Imagery. Controlling the controllables. And then kind of self-talk. So kind of reactive versus kind of this idea of leaving possibility.
I mean, you could see so many of these things are talked about in the pain world now. I don't often see them grouped together like this as sort of a protocol or a plan, but it is, this idea of using breathing to activate your parasympathetic nervous system and get out of the sympathetic area. Imagery is talked a lot about. I've seen some studies looking at it with post-surgical conditions, like maybe you have back pain and you can't get up and do a lot of movements, but just visualizing movements and firing some of those motor circuits and kind of
crazy that you can do that with just thinking about a movement. There's I think a basketball one that did the same thing where they visualized shooting free throws. And one group actually shot free throws, one group just visualized, and they both improved. Yeah.
It's so cool. Yeah. That stuff's amazing. I mean, I knew it makes sense. I remember, I don't know if you remember doing this in your athletic career, but when I was in gymnastics, for sure, I would do a lot of mental rehearsal and imagery because you're going through a series of things, and if you fall or something, it hurts. I had times where I'd land on my head and really, you get kind of freaked out about that, and visualizing and imagining yourself doing it successfully really was helpful.
Yeah, it's those mental reps and your body and your brain is actually probably firing the same motor patterning even though you're on the ground.
Mm-hmm.
And the brain probably still lights up, which would be fun to do a functional MRI on gymnasts who are thinking through the routine. But it's giving you those additional reps that you can't do because you only have a limited number of attempts before fatigue sets in and you start to not be able to perform as well, and you risk greater injury. So maybe you do a couple practice ones in your head first, and then you do 2 or 3 attempts, and then it's like, okay, back to the imagery because that's all I got today. And you're just trying to stay healthy.
Yeah, it's cool. I think, you think about these 4 things and getting that improvement in performance, and I think you see a lot of these things help people with pain. It's almost like, I think you kind of said it earlier, it's like you've got education, and then you're kind of helping set expectations, and you're giving people kind of a tool set and a roadmap to figure out how to navigate being uncomfortable. And it's amazing how, when you have things like that, how much more willing you are to push or to keep going through something when you've kind of got you've got a strategy. It's not like you're going at it blind. You feel kind of confident that somebody's trained you in something, and you just know how to deal with it a little bit.
Yeah, and I even think, I'm not a PT myself, but as a PT, your probably biggest issue is this whole idea of adherence at home.
For sure.
And when you think about like controlling the controllables, like you can't control how they're going to respond. You can't control the fact that they already have an ACL injury, but they can control their attitude towards rehab. They can choose to control and do the actual rehab at home and make it almost like a job for a while, where it's like, I want to get back to doing what I love. This is how I do it. And I think, and again, I don't know where the research is on this, but this whole idea of doing mental work, which will help with exercise adherence, which is going to help improve range of motion and strength faster, that might be a game changer. And trying to understand how it's working could be really interesting.
I think you and I were talking about this, the potential for research in that area, because I haven't, it's not an area that I am searching out a lot, but I haven't heard many people talking about this. It would be, you see aspects of it in different places, like in the pain world, there would be booklets and videos that were given to patients when they'd come in that would sort of be like pain neuroscience education to help kind of maybe change some of that mindset and help them frame pain a little bit differently. But
kind of in that biopsychosocial model that you love to talk about. It's like, okay, what are the psychological factors? What are the social factors? And trying to re-educate. It's like, not all pain is pain.
Yep. Yeah, like giving people like, just having that educational piece and giving them some of the strategies up front. I bet you, you just have to imagine if every person coming in for an injury or pain, say you had that ACL individual, and how amazing would it be if it was like you had videos and information kind of showing, this is the process this is what the ACL rehab process kind of looks like, that's going to get you back to being functional in life, getting back to that sport or whatever. Because so many people, they're coming in and it's like you have each session and the person, maybe the PT is telling you some things, you're getting some small bits of education each session, but it'd be pretty neat to have something up front that helps you it's like anything, like right when we do lectures, if you have an outline slide at the beginning of what this lecture is going to entail, it helps people. It just gives you kind of an idea of what's coming ahead. And to have that in performance, in rehab, it would be pretty cool to study that and see how it affects outcomes.
And then, you layer a little bit of the mental training component on top of that.
Yep.
Because I like to think of NFL to a degree here, where rehab times have gone from a year to a little over a year for ACLs, and now within 6 months, sometimes they're back on the field.
Yeah.
Yes, there's been a lot of advances in surgical technique and rehab, but the pro athletes are also working with sports psychologists, and they have a whole training staff, and they're trying to do everything they can to get them back. And there's all of these other factors outside of just the rehab that are allowing them to move through to progress faster. And I think trying to bring that down to the average individual would be amazing. So, how many ACL people never get back to full function? And if we can bring more people back to close to where they were beforehand, or even better, going back to the beginning of our conversation, give them a way to get stronger than they were before.
Yeah, that's a huge piece. I think that's talked a lot about. That's talked about quite a bit now, especially in the ACL world, and I think it applies to all injuries, but not only, of course, the kind of traditional physical factors that would go into rehab, the strength and mobility and all those things, but just a lot of times they'll talk about their psychological readiness. And, fear of re-injury is a huge thing.
Yeah.
I mean, when I was going through this chapter in the book, I remember looking at some of this. There's a lot of studies, especially in ACL injury patients, looking at how much that fear of re-injury can increase their injury risk and just hinder their ability to get back to full function. And I think, like you said, if you're a professional athlete, you probably are more likely to have access to sports psychologists and kind of, my friend, I don't know if you've ever met Jeremy Bettel. He's he was here in town for quite a while and just came back. He has PhDs in human performance, and he was talking about working with different, in his role as this performance medicine director with a lot of these teams, it was kind of bringing together all of these different specialists and setting up processes where they'd all communicate. And, I think you see in that professional sports world, those athletes have access to all of these different individuals who are helping them with all these facets. The regular individual, a lot of times when they're thinking about rehab or performance, it's just strictly kind of their physical body and maybe the mental side. I think more people are becoming aware of that, like grit and just kind of mental toughness and things. But there's so many aspects we miss that you could take some of these things from professional sports and figure out how to get them to the regular individual.
Yeah, I mean, I even think of something you said there with this readiness component.
Yeah.
Because if we think of like the biomechanics of a jump, for example, and if somebody is going to approach a jump from a passive, nervous standpoint, they're not going to be on top of their leg as much. They're going to be kind of leaning back, which if we're looking at an ACL, leaning back with a knee bent is setting you up for another ACL tear.
Yep.
So it's this idea of getting them ready, mentally ready, and walking them through. It's like, you're being passive right now. Here's why that is bad. Whereas if you're actually aggressive, you're putting yourself in a better position and you can reframe it in their mind. So they start approaching things with a better posture, with a better biomechanical stress to prevent that.
Yeah, well, that's such a classic one with ACLs where you see kind of a stiff landing. They use less knee flexion excursion. But you can imagine why they would do that. If you've injured, you're apprehensive. You feel like, oh, if I let my knee bend and use it, I'm more likely to hurt it. But it's the exact opposite.
Yeah.
If you don't bend it, all that stress goes in those passive tissues. You're not using your muscles to eccentrically act as that shock absorber. And now you're more likely to tear your ACL. But it's all that education and getting them to trust their body and understand that, biomechanically you want to use your muscles. And I used to always, when we'd have people test them and have them land on the force plate, I'd always say, try to land like a ninja, because sometimes when you say that, people will just they'll naturally use their muscles more and try to shock absorb.
It's always fun to kind of think about how do you educate people as well, and how do you give the cues. The cues and the connections are always the fun part with education and with teaching and with working with patients.
Yep. It's so much of, we sometimes, I think, don't appreciate language and communication and how important it is. I mean, I remember I used to give friends a hard time, or, I was a communication major in college, and you'd kind of think of it as like this degree that wasn't that important. But the longer I'm in physical therapy, I say this all the time, but I realize, particularly I'm seeing a lot of people in pain, that it's almost more therapy, psychological therapy sometimes, than it is what I'm doing from an exercise standpoint or manual therapy standpoint. And I think, I don't know, maybe I've told you, my mom's a psychiatric nurse practitioner. And so I think I grew up in this very communication heavy household, kind of open communication. I took it for granted. I didn't really think about it. But now the longer I'm out, and I got really into for a while reading research on back pain, people with back pain, and how clinician delivered language and the messages that are given, how that can impact an individual's recovery. And I think you and I both know, like, especially if you're teaching in the classroom, you can say something and think it makes a lot of sense, and somebody doesn't understand it at all, or it means something totally different to them, and just how important that communication side is.
And I think that's something people fail to understand until they've been in a job for a while. Whether it's a teaching, a working with a rehab, it's the communication and how you frame things that affects the brain and the physical outcomes so much. And I even see this within teaching. Students don't appreciate the communication type classes. It's like, I'm never going to use this. And it's like, come back to me in 15 years.
You're going to be using it all the time.
And it's this idea of even how do you teach someone to move properly? How do you break down a movement? How do you give cues? Like education around explaining a movement is so lacking. I just remember thinking of again, my Fit for Life class, trying to break down how to do a squat.
Yeah.
To you or me, doing a squat is the simplest movement there is. But if somebody's never done a squat and doesn't know how to move their body from an athletic perspective, it's actually a kind of complicated movement.
Mm-hmm.
So it's like, how do you break this down? And I went and got a chair. I was like, okay, sit down in the chair. And he sat down and did a squat like I wanted. Then I took the chair away. I was like, sit down like you're sitting in a chair. And he wouldn't do it right.
Yeah.
And he didn't understand how it was different. Mm-hmm. And thinking about the stresses on the knees and the body and the cues, it can sometimes be really hard to communicate properly. And I wish all physical therapists and personal trainers had that communication background to properly break down a movement.
Yeah.
And that's, I think, what separates a good physical therapist and a good personal trainer from someone who's just okay.
I totally agree. Yeah, I think it's so much of what separates people is not necessarily the knowledge they have, but how well they can actually communicate those topics and, and teach, really. I mean, I think that's really good clinicians are ultimately usually pretty good teachers, and that squat example is a perfect one because, yeah, if you're used to coming from an athletic background, those movements often seem very second nature. But when you get someone in who doesn't have that background, you see really quickly how much you kind of take for granted just the awareness you have within your body and knowing kind of how your body moves, how to use certain muscles. Just people who don't have that background, it's challenging. And you're sitting there, you're like, sometimes you're like, I don't know what cue to give this person right now. The squat one with the chair is amazing. But yeah, you're right. You take the chair away and sometimes people they can't figure out how to replicate what they just did a second ago. They don't know what they did with their body.
Yeah, and it's one of those fun mysteries of teaching.
Yes.
And it really, anyone can teach an exercise physiology class or a biomechanics class, but to have analogies that click and to be able to break down a really complicated topic is where it gets more interesting.
Yeah.
And it takes time. I mean, I look at one of my colleagues who's been teaching for 40 years and I'm nowhere near where he is. And I mean, I've only been teaching for 10 or 11 years. I've got time, but it really does take repetitions. It takes looking at different things from different ideas. It takes reading research. It just takes this accumulation of time to become a really good teacher.
Mm-hmm. Yeah, it's like I sometimes feel like, I was listening to, I don't know if you've ever looked at Arthur Brooks' stuff. He's a Harvard professor that's, he studies happiness mainly, but I want to say he's a social psychologist. I might have that wrong, but he talks about kind of these two kind of different phases as we age, kind of as humans. And early on, say when we're in kind of our teens and 20s, it's when you have, I'm going to forget the name for both of these phases, but basically early on you kind of really have the real intellectual power, the ability to learn new concepts. And it's when a lot of people who generate new kind of world-changing ideas, they're often younger. And then as you get older, you transition into this second phase where you might have a more difficult time. I think I notice this myself now being in my early 40s that I might not learn things or pick up new things quite as fast, but you have your ability to teach and synthesize information and recognize patterns improves. Mm-hmm. And I think that you're right. Sometimes people try to rush that early on. I see that with a lot of new PTs. They want to just get out and they're expecting that they'll have all these patterns and all of that right away. And it really takes the time of teaching and working with lots of different people and putting in the repetitions to where you start to appreciate those patterns and, and to be able to know how to teach in a way that is effective and people, and still I'm in the same boat as you. I look at people who are 20 years ahead of me, some of these PTs, and I look at how amazing they're able to connect with people and build rapport and teach concepts. It's just a constant evolution. It's like you look at that and you're like, I'm doing all right, but I can see where I need to go.
Yeah, it's always fun to kind of be looking ahead, but it's also really good to look back, which most people forget to do. And it's like, I've come a long way. I think of where I was when I first started teaching. I was not that good. I thought I was. I wasn't.
Yeah, you have to celebrate that stuff because you do forget. I'm the same. I mean, I'll forget. It's so important to look back and celebrate kind of those accomplishments and look at how you've changed. Otherwise, I think especially in the world today, especially if you're kind of a success achiever-oriented person, you're always looking ahead at, and you can start to feel like, oh, I don't have that. I'm not at that spot. This person's doing better than me. But to look back and see where you've come from is so important. Tim, thank you for coming on. Is there, I always like to ask people, I could talk to you like 100 times about different topics. So, but in the grand scheme of today's conversation, is there anything, maybe, I know I told you beforehand, I really wanted to jump into, you have such a specialty in exercise physiology. Is there anything, thinking about people who are maybe coming to this as kind of the general population, thinking about health, pain, injury, maybe some different practitioners in there? Is there anything from your background anything else you'd maybe want to highlight that we didn't touch on? That's a really broad question. But...
I don't think there's anything really to add. I think the big one is just that I'll bring in the American College of Sports Medicine once more.
Awesome.
And their big motto is exercise is medicine. So if we're talking to the general population, exercise is medicine. Moving your body, lifting heavy things, it's going to help prevent a lot of disease down the road, blood pressure, heart disease. And if you're just at the beginning point of exercise, just move. Your body is going to feel better long-term if you move. It might not feel better tomorrow. If you move for the first time today, you're probably going to be a little sore tomorrow. That's okay. But over the next couple of months, your body's going to start feeling better and better. You're going to be able to do more and more, and you just have to stick with it.
I love that. That's so important to highlight. My back's starting to hurt sitting here. I thought for a while, I was telling Ben that maybe we do walking treadmills for the podcast, but it's a lot of movement and it's a little harder to be in front of the microphone.
A lot of noise.
Yeah, no, I love that. I love, just encouraging people to move. And I think what you said, that we know movement can really make you feel better and help you with so many disease processes. But if you're new to movement, you might get a little sore, and don't let that kind of deter you. You just have to, like you were talking about earlier, whatever your form of exercise or movement is, you've got to make sure to build in the recovery time and then just like keep at it. And over time, your system will adapt. And yeah, there's, it's amazing how I feel so much worse when I'm sedentary for too long, and just adding a little bit of movement, just sometimes even just going for a walk. Like, it's amazing how good it feels.
That's a great starting point.
Yep.
Just go for a walk to start and gradually build.
Yep.
There's no need to be running a marathon tomorrow. Take your time. Progress slowly, gradually overload, and try to prevent that soreness.
Coming from the exercise physiologist. Thanks, man. Thanks for coming on. I really appreciate the time and just sharing about all your knowledge. I'd love to get you back on again at some point, and we can dive deeper into other areas of exercise physiology and what you study. But thanks again for coming on.
It's my pleasure, and thank you, Tom.